Hi everyone, thanks for giving up your time on a Friday afternoon and for giving yourself over to what can actually be a very dry subject, but is really important to know about, particularly if you're a health or social care professional, and actually also if you are a family member or a person with Huntington's disease, because chances are this subject will loom large in your life at some point. My name's Alex Fisher, and for those of you who don't know me, I'm an occupational therapist in the West Midlands Regional Huntington's Disease Service. Okay, so I've entitled this, "In order to play the game, you've got to know the rules." And I think this is really particularly important to continuing healthcare assessment. And what underlies that is that the rules of the game are the absolute imperative of the importance of evidence. This is for anyone who provides evidence to the continuing healthcare assessment process or review process. Okay, so because there is an assessment process, in other words, when the application is made for continuing healthcare, and then it's regularly reviewed. So the process does not stop after assessment. It is a continuing process. It's really important that you know that, because then that means that the evidence still needs to be collected in order for the individual, if they qualify for continuing healthcare, to remain on continuing healthcare. So the goals of today's session are to understand continuing healthcare funding, because it's quite a thick subject and it's quite a complex subject. To understand what a health need is versus a social need. And again, this is a really controversial area because, as we all know, a social need might impact on a health need and vice versa. To understand when and who makes the application, and to understand the level of evidence needed. What is CHC, continuing healthcare funding? Well, it's funding provided by the NHS. That's health. So it's not provided via social care, it's provided via health. So two distinctly different things. Although, again, my personal opinion is actually there's not a huge amount of difference, they're just on a continuum. Continuing healthcare funding means that the person does not have to make a contribution towards that part of their funding. So if funding is via continuing healthcare, they do not have to make a contribution. Whereas social care funded, there's a contribution element. Hello, anonymous attendee. Your question is, when the review takes place, if there are differences of opinion in the level of need, why is it only the views of the professionals that is looked at? The answer is that in the national framework, that should not be the case at all. So if you are an advocate for a person with Huntington's disease or the person with Huntington's disease themselves, then your view should be taken into account. And that's in the framework. Okay. So, okay, I'm just gonna, so I can see my screen, move myself around a little bit. Okay, getting on to what is CHC funding again, and it's designed to meet a need which results primarily being a really important word, from a health condition, not based solely on diagnosis. So whilst we're doing this through the Huntington's Disease Association, it's really important to say to you that actually just because you've got Huntington's disease and that's a health condition, it does not mean automatically that you will get continuing healthcare funding. Okay, really important distinction. So I'm really sorry for the wordiness of this particular slide, but this is taken from the Continuing Healthcare National Health Service Framework document, and it gives you a definition, although it's not a legal definition. By the way, those things don't exist, so this makes it all a little bit more complicated, and that's a massive complaint about the process. It gives you definitions of what is a healthcare need versus a social care need. And I really like these two definitions. So a healthcare need in general is one that relates to the treatment, control, prevention of a disease, illness, injury, or disability, and the resultant care and aftercare of a person with these needs, whether or not that is carried out by a health professional. So, for example, say you qualified for continuing healthcare funding as a person with Huntington's disease, and it was agreed that you took what's called the payment in a personal health budget. It might very well be that the people that are delivering your care, even though it is health care, so for example, suctioning, for example, which is when excess saliva and mucus is sucked out of a person's mouth, that can be delivered by a social carer, or that can be delivered by a family member. Okay, so it doesn't need to be delivered by a health professional, but it is a primary health need. And then we've got, okay, what's the difference between that and the social care need? So the social care need is focused on providing assistance with activities of daily living. So in other words, eating and drinking and personal care, maintaining independence, social interaction, enabling the individual to play a fuller part in society, protecting them in vulnerable situations, and helping them to manage complex relationships. So you can see that there are distinct differences, but you can see that there are overlaps. And in Huntington's disease, there are absolutely overlaps. And there are some cases where a person complies with the application of social care, and therefore actually it is monitored and maintained really quite well. And then there are individuals who have more complex needs, usually to do with behavior that challenges communication, nutrition, swallowing, mobility, that it kind of overlap and fall into health. And that's where we need to sort of start to think of the overlap. When and who makes the application? So I'd like you to think of this as a continuum, a bit of a timeline, right? Okay, because I know that there are people out there that might be privately funded. But ideally what should happen is that the person should have an assessment under the Care Act. Now that's undertaken by a social worker, right? And what that does is that matches you up against the criteria of the Care Act to see whether your needs can be met through social care and other informal systems, formal, informal, local healthcare, so on and so forth, yeah? But that's where I would go primarily. And so if you like, is a sort of a level, as an entry point, which you need to get onto, and then you go through that process. So you build up through this process levels of evidence. And I'm sorry if I keep banging on about levels of evidence, but this is what needs to happen in my experience, because what will happen is continuing healthcare will say, what have you done? What have you tried? What's worked? What hasn't worked? So a person should ideally have an assessment under the Care Act. And then, can those needs be met through informal systems, formal social care systems, local health care, such as, okay, can an OT go out? Will they engage with an OT? Will they engage with a local physio? what rehabilitation has been tried, will they engage with the local CMHT, can all of those needs be met through that? And through doing that, you start to build up your layers of evidence. Now, trying all of these things, but the health needs are still not being met, and they're predominant. Okay, in which case, if you've been through this process here, I'm just checking there's no questions, then what happens next is a healthcare professional and or social worker, in conjunction with others, so OT, physio, nurse, whoever is involved, GP, completes what's called a continuing healthcare trigger form. The links, by the way, are on the end of this, this presentation today. If the person triggers, so in other words, what is seen by filling that form in as a group of people, a high and predominant level of health needs, and there are numbers, by the way, so it's like, okay, so many A's, so many B's, so many C's, because they're sort of put in categories. Then the lead professional, and that's by negotiation usually, sends it off to the local continuing healthcare. So that's the local CCG. And at that point, what is then organised is one of the next stages, which is called a decision support tool, MDT meeting. Okay, now I think there was a question prior to this presentation today about who's responsible for leading on completing the trigger form. I mean, it should never really be just one professional, but one of them needs to negotiate who's leading on it. And the ideal person, if you've been through this process, I would say, and for me, working in the system that I work in, which is right across the West Midlands, I have to negotiate with social services usually, and a allocated social worker, that they are the hub, if you like, because all of the information will go in and come out again. And if you think about it, what we're trying to do is define what social care needs are and what healthcare needs are. And so therefore, very much a social worker needs to be involved. But it can be a healthcare professional, and it should be in conjunction with the person with Huntington's disease, ideally, if they can understand the process, if they can advocate for themselves, if they can communicate. All of those things need to be considered. Can they consent to this process? And if not, why not? That, by the way, will form part of the evidence. Then actually it can be an advocate, it can be a family member, a nominated family member. So yes, so then the trigger form is sent off to the local continuing healthcare, CCG, and then they will then organise the assessment and the collection of evidence. Now, I've put a little star here at the bottom. If the person is nearing end of life, so a terminal phase of their illness, then the process is slightly different, and it does need to be a healthcare professional rather than a social care professional. Okay, and at the end of this presentation, there's a link to what you do for fast track and terminal. And it talks very much about, and again, I know in Huntington's disease that the palliative stage, or sorry, the end of life stage can be quite protracted. People can ebb and flow, but that needs to be taken in consideration. And also timelines need to be taken into consideration. Now there's somebody in the chat, so I'm going to go to that. From Peter. Hi Peter, does mental health needs come into the assessment and evidence? Yes, absolutely it does. That was a very quick answer. Yes, totally. Yeah. And when I show you what the health needs are, you'll see why. health needs. What do I mean by that? So I've already given you the definition. Sometimes health needs are referred to as nursing needs, but does not need to be delivered by a nurse or a healthcare professional, but are nonetheless health-based needs. And they're continuing health needs. So they're ongoing health needs. And as you can see down the side here, this is the domains. So that just means sections that the NHS have said these are health needs in comparison to social needs. Health needs, breathing, okay? Nutrition. In Huntington's disease, this is one of the uber important ones. This is about unintentional weight loss, as we know. So, you know, if you are a person and you're delivering care to a person with Huntington's disease and you're noticing weight loss, then you start the process, you collect the evidence, okay? If they're choking, if they're coughing, if they're getting frequent chest infections, okay, there's a crossover there, isn't there, between breathing and nutrition. And that also is part of the criteria, because you have to show the complexity of the condition. And Huntington's disease is a very complex condition, and each area, each of these domains often overlaps with another one. It's really important in your evidence that you show that. So breathing, okay, frequent chest infections count on here. How many? How often? How often have they had to go into hospital? What's happened in hospital? Do we now need to wear, I don't know, a hyacinth patch to stop salivation? Actually, all of those kinds of things are evidence. Don't ignore them. They need to be documented systematically. Nutrition, okay, unintended weight loss. Are they on supplementation? You know, as a member of a social care agency, you might be going into the fridge and you just might be going, oh, well, you know, it's just a 40 sip. But actually, they're taking 6 40 sips and they're still losing weight. Okay, that needs to be documented. You're going in, there's half a 40 sip left on the side. That needs to be documented. It needs to be really systematic, and you're part of that process. Dysphagia is really, really key. Again, a key health need in Huntington's disease that kind of often gets overlooked. You kind of go, all right, well, we're helping them to eat and drink. Actually, why are you helping them to eat and drink? How long does it take? If you don't do it in that way, what happens? Are there special spoons that you're using, i.e. anti-spasm spoons? Those kinds of things are really important health documentation. Continence, okay. Now this doesn't have to include just being padded up. This is about actually catheters, management of catheters, UTIs, the frequency of UTIs, the frequency of antibiotic use. Is the person able to look after their skin, keep it clean? Why can't they keep it clean? Is it because actually they don't have an understanding of their personal care needs? So in other words, as a social care worker, you might actually be assisting that person with their personal care, and they're letting you do that. But in Huntington's disease, we know, sure as eggs are eggs, that actually sometimes people don't allow that to happen. And then they get sore bum, and then they develop pressure care problems, and so on and so forth. So that's an interlap, an overlap between each domain. Okay, hello. Hello, Elena, again, including wound care. Now, I would say, and I was on a trigger meeting yesterday, we discussed wound care of a lady, and actually what we were discussing was the overlap with falls. So falling frequently, getting wounds which weren't just as a result of ulcerated skin due to incontinence, but were actually as a result of injury, and how those wounds are managed. Mobility, okay, again, Huntington's disease, frequent falls, okay. What's been done? What's been tried? Why is it not working? Why now does it need health care funding, okay, because it might be managed quite well otherwise. So you're stepping into that sort of thinking a little bit more broadly, and you're pulling in your knowledge of Huntington's disease. Okay, so a person won't comply, for want of a better word, with physio guidelines. Why not? Is it because they're fixed and rigid? And is it because actually they've got executive dysfunction and therefore they've got no judgment of risk? Is it because they're impulsive? All of those things, as you can see as we're going through here, you need to comment on, but you need to comment on the interaction between each. Communication. People often have profound dysarthria, okay, and struggle to make themselves understood. Therefore, actually, do they need somebody translating for them? Psychological and emotional needs. So Peter asked earlier on about this. You can see that this includes mental state, Peter. So actually, this is anger, anxiety, low mood. This is psychosis. This is all of those kinds of things that you were talking about, okay? Cognition, we've got understanding here. So earlier on, I mentioned people actually being able to consent to this process. Now, it might be that they can't, which might mean that they've got problems with their cognition. So therefore, that's part of your evidence, okay? And cognition in Huntington's disease, you should define what you mean by that, because this process is a little bit old-fashioned. And actually, it often talks about cognitive impairment being about short-term memory. But it only gives that as an example. Actually, cognition in Huntington's disease, we know, is about attention, concentration, executive dysfunction, impulsivity, and apathy. Now, if all of your social care, well-intentioned social care and healthcare in the community is falling apart because of these things, that's where it needs documenting. And that's where, again, it overlaps with other areas. Behavior, okay. This is an area, and they talk about challenging behavior. Now, in Huntington's disease, challenging behavior, and again, I said this to a social worker yesterday, actually might not be somebody coming up and thumping you, although that can happen in Huntington's disease. So it might very well be that the person is so apathetic that they can't engage with anything at all, and that is a behavior that challenges and communicates a need. Drug therapies and medicine, again, compliance, peg feeding, all of those kinds of things come under this. Altered states of consciousness, people with HD, lady yesterday has HD and epilepsy, is falling. We don't know because we can't quantify the falls, whether that's actually happening as a result of poor mobility, or actually is it because she's not complying with the medication and actually she's actually getting epileptic seizures which are causing her to go to the floor. All of those things are really important. So altered states of consciousness are usually lack of awareness, lack of consciousness, epilepsy. And then we've got other significant care needs that are health related, but perhaps don't fall into this. Now, the person earlier on was asking about why is just the professionals need taken into account, and I said to you that that shouldn't be the case. But actually, other significant care needs, sometimes what I've done is I've actually gone to the loved one and I've kind of gone, you're living with this person, what's happening for you? And that can then be put in there as well. Because again, there's that overlapping interconnectivity between all of these. So what's next? This is, so you put your application in, so a person has triggered and you've put your application in, and now continuing healthcare assessor is going to come out and do the assessment, and that's called a decision support tool meeting. So a separate form. Again, you can follow the links at the end of this presentation to see the form. and you can make yourself, and I would suggest you make yourself familiar with the headings, because that's going to help with your documentation. But I've also entitled this Making the Invisible Visible, because in my experience, what happens is that you guys are so busy, if you are in a nursing home, residential setting, providing care in the community, that you just kind of accept it and it's not documented. So by this I mean, okay, and I've got Ruth to thank for this one. If I do not give Mr. Bloggs his cup of tea at 5 o'clock precisely, then Mr. Bloggs is actually going to become aggressive and hit somebody, right? But what tends to happen is we gave Mr. Bloggs his cup of tea at 5 o'clock. And actually what is lost there is why you must do that at 5 o'clock precisely. So what's really important here is that you make the invisible visible. Now, I know that you're all strapped for time, and even more strapped for time. And I don't want to make a rod for your own back, I really don't. But people can sometimes lose funding because the invisible is not made visible, okay? Again, this will have to be based on evidence, which is why, anonymous attendee, it's really important that if you're listening as a family member, that actually you're aware of all of this stuff. And that's why you need to get savvy with looking at what they define as low and what you define as moderate. You need to take the emotion out of it and be, quite savvy about what they're defining as moderate. And then you need to offer the evidence. So one of the most successful family members that I ever met who went through this process started to keep a diary of needs and what was happening every day, and kind of got a little highlighter and colored them, and then was able to kind of go, right, this happened on this day, and this happened on this day, and this happened on this day, and was able to demonstrate what you're talking about. If the evidence is there, then the argument is easier. So it's about making the invisible visible, okay? And that's why we all need to work together on this. But an emotional argument, and I'm sorry to say this, in the middle of a DST or a trigger meeting or whatever, sometimes very the assessors are very cut and dry, and the argument from one side can be a little bit emotional, quite rightly, because you've got a lot riding on it. But actually I would say take a step back and actually look at what the levels are and actually collate the evidence if that's possible for you. Okay, so making the invisible visible. I'm going to give you 2 illustrations. I hope I'm doing okay for my time. So, okay, number 1 is a community case, and number 2 is a residential case, because this webinar was designed for community social care and healthcare staff and residential and stroke nursing home staff. So although everyone is really welcome, okay, so these are examples where it's kind of falling down, and I don't mean that as a pun, by the way. This is where the evidence is falling down and where people don't get what they need. And today's purpose is about showing you the level of evidence that's needed. So number 1 is a lady who lives alone currently. She is in the mid stages of Huntington's disease. Her mobility is probably some of the worst mobility that I've seen. She is, to my clinical experience, falling daily. As I said earlier on, I think I mentioned she's got epilepsy as well. And she's got profound weight loss. She doesn't want a peg. So there are wishes and values here that are trying to be adhered to. And she has care staff that go in 4 times daily, but that's not meeting her needs. So if you remember what I said earlier on, I go in and I kind of go, crikey, this is not meeting this lady's needs. But because she's got an established social care package, there's not a social worker involved. So what I did was I went, right, okay, these needs aren't being met, these needs aren't being met, and this is for why. So this is my professional opinion. This is what needs to happen. Made a request to social work for a new social work care act assessment, which obviously nowadays can take some considerable time. But so she's at home, falling, rapid weight loss, swallowing, but this had been going on for some considerable time. And actually, the agency that was going in weren't communicating to one another cohesively and consistently. And it hadn't got anywhere near health or social care for a review. And I didn't quite understand why. Now, I'm not social care agency bashing, not at all. But when I did eventually get in touch with them, they were like, yes, we're really, really worried about her. We know that she's falling daily or more than daily. We often go in and find her on the floor. We're really, really worried about her weight loss. And so what we've now said is, right, there needs to be this really consistent process of talking across the board about what needs to happen next. And so we've now got social worker involved. And yesterday we met, so physio met, dietitian met yesterday, speech and language therapy met yesterday, social worker and myself met yesterday. The lady didn't wish to be part of it, and any of her loved ones didn't wish to be part of it. And we did, and we sat and we did the trigger form, and we've agreed that she triggers, and it's being sent off by the social worker to the CCG. So the next thing that will happen is that there will be a decision support tool meeting, and we will talk about this lady, and we will argue and debate her health care needs to see whether she actually can get health care funding to try and be at home for as long as we can keep her safely at home. But I guess my point is that a lot of this evidence might be missing because there was that lack of cohesion and communication on the ground, which again, I know is really, really hard for an agency, particularly the massive agencies that cover the massive cities. But if we want to stop penalizing our Huntington's disease loved ones and people that we care for, then this has got to change. We've got to provide more systematic evidence. Okay. Now, getting on to the next one, it's actually about refusal of care within a residential setting. And again, I mean, this gentleman's in there, it's being paid for by social care, but the gentleman was reported to be refusing personal care, medical care, food, fluids for between 12 hours and 72 hours a time, at least once every 2 to 3 weeks, probably even more. And people were saying he needs more care, he needs more care, he needs to be funded by continuing healthcare. This all comes from a primary healthcare need. But actually, when we went in to actually have a look, none of that was documented. So there was this report that this was happening, but actually nothing was actually documented to that extent, or at least that was obvious. So then when the continuing healthcare assessor came, they actually couldn't find it, and the gentleman was turned down. So then we had to go through a review process of actually revisiting all of the care plans, revisiting what's documented, what isn't. Is he capacitous? Isn't he? And so that led us through the process to get to more evidence. And we're now in the process of revisiting continuing healthcare, because his illness is making his care very challenging, and it's above and beyond social care input. And it requires really, really skilled care and really, really skilled knowledge. Hello. Tiffany, okay. Once the DST has met the triggers and it is sent off to the CCG, further assessment is carried out, I assume. Are all the professionals you mentioned, physio, SLT, dietitian, then involved at that point too? Yes, absolutely. So we don't stop at that point. We've all agreed, and it should be discussed, that we will be available, or our reports will be available for the DST, for the meeting. Ideally, we'd all like to be there, because actually we all want to debate with continuing healthcare as to this lady's level of need. And sometimes, if you are not present and you've not necessarily put your point across in the report, then that can get missed a little bit. So it's exceptionally time consuming, but ultimately worth it, I think. And this is where we need to get a bit savvy. We need to get much more savvy with the language. We much more savvy with the evidence levels. I hope that answers your question. So, what am I proposing here? Now, I'm not proposing an answer for you, by the way, because I can't, because all your systems are completely different. But what I'm saying is that in order for us as a group of people that work with people with Huntington's disease, that want the funding so that they can, that recognizes their health condition, we can't just say, oh, they didn't get continuing healthcare. We have to be an active part of the process. So there needs to be more, oh, sorry, here we go. Hi, Alex. This is Jo. Hello. We've not met yet. I think we're due to meet. We frequently find that we end up with 50-50 funding, as so many people of our HD people don't fit into one box or the other. Is that similar with your team? Yes, there is joint pools of funding, definitely. And that's best practice, actually. That's really, really best practice. But it should be dynamic. So if it changes, and if there's more predominance towards health, then that's what needs to happen. And so it can be 80-20, it can be 50-50. And then, of course, you go to a process and you've set this up beautifully. And therefore, the continuing healthcare assessor comes in and the review and says, oh, well, everything is fine now and sorted. So actually, they need to go back to social care. And that in itself is probably a webinar for another day about how we argue ongoing need. This is just because the need is met doesn't mean that the need is not still there. It just means that probably providing really, really good care in the way that it should be provided doesn't mean that the health condition has gone away. We need systematic documentation, which includes risk assessments and capacity. So, for example, if we're saying mobility, falling daily, how often are they falling? What have we tried? Why won't they engage with physiotherapy? Why is a falls device not working? All of those kinds of things, so that you're showing that all the social care things have been exhausted, and actually this is predominantly due to the health need and needs that additional support mechanism. Care plans which reflect complexity of and interaction between the health domains as well as social domains. In HD, this often requires more than one for each area. So the chap that was refusing the residential, there are 3 care plans. There's a care plan for a good day, there's a care plan for a bad day, and there's the care plan for the in-between, when actually if he goes over 12 or 24 hours, what do we do then? And that includes fluctuating capacity, which then comments on his cognition, for example. and there's an advanced plan should he need to go into hospital. Okay, one second, Q&A. Peter, hi, I have a private physiotherapist who treats my wife on a regular basis, not from the NHS, and they've done this for about 5 years. Should I request some form of report from him or her, and would this be allowed to be included? That's a really, really good point. The private physiotherapist will be on the HCPC register, Peter, and I do not see why not. But if I were you, I would check it out, and maybe check it out with your local continuing healthcare, or perhaps even ring up Beacon, who are a free service that can advise on continuing healthcare applications and, I suppose, fiddly little bits that might be out of my line of sight. And again, at the end of this presentation, there's actually a link to that, which is actually on the NHS page, NHS UK page. Okay, where were we? Right, yes. So this often requires more than one care plan for each area, and there's an interactivity, a clear interactivity between each area. Many of the things that we're called out to as the Huntington's disease team, we often find are as a result of a lack of collective and consistent thinking. And I know that's really, really hard because, you know, in residential homes, nursing homes, you've got handover, you've only got 10 minutes. In some, obviously in social care teams, you perhaps don't meet up with your colleagues, but I would suggest that actually this needs to be part of that. If you're going to take on somebody with Huntington's disease, you need to think about that. You need to think about it, because number one, it will make your life a heck of a lot easier, and it will optimize your engagement with them, but it will also make this process a lot easier as well. And it will optimize the person's ability to get the funding that they need, because we're not about penalizing folk, I don't think. And then there's a understanding and agreement on the reporting chain. So again, that's why I'm asking you to get a bit savvy on the process, which is kind of what we've run through today. But also, like with Our Lady in the Community, there was no reporting back to the social care agency, to the management and the social care agency. So all the local lads and lasses were kind of going, we're really worried about her. But actually, and they didn't document it, and they didn't port it back up the chain. So then there's this consistent reporting back up and back down. For me, you shouldn't get in trouble for doing that. You shouldn't. Absolutely not. You're doing your job. If you have been given quarter an hour with this individual and you're finding that at the end of that time you've followed the care plan and there's still outstanding needs, report that back up the chain, because that needs to go somewhere, because that's evidence for what we're talking about. And then finally, get savvy on referrals. Who's been referred, who has referred who to what service, what's happened, what was the outcome, what was the recommendation. As Peter said, get a report about needs and what needs to happen, and why currently the current systems aren't working for this individual, and therefore why there needs to be this consideration for continuing healthcare, because it's the primary issue is the health need. Okay. And finally, here are the key documents. So this is nhs.uk. It's not the NHS England site, but it's got links to the NHS England site and .gov.uk, and it's very clear. And even me at the end of a very tired day, I'm kind of okay reading it. It includes a link to Beacon. They're an agency that are free who can provide advice. They've also, if you register with them, they can send you a tool on what happens, and some of the, and that might help Peter, actually, there might be your answer within that. If it goes above and beyond, they do charge, but they're quite transparent about that. But at the point of just ringing their advice line, it's free. And then this other link is what is a fast track assessment. So in other words, approaching end of life and terminal, and what that actually means, and what the framework, the continuing healthcare framework, actually says. Now that's on a site called provided by a company called Compass. They do charge for services, but some of their sort of small pieces on breaking down the legalities and the legislation and the words are really, really good. And that is it. So I'm going to stop sharing. And I guess it's kind of like, are there any questions? You might all be asleep because it's Friday afternoon.
Thanks very much, Alex. That was great. Yeah, if anyone has any last questions, if you want to pop them into the chat. And there's a question here, Alex saying, I sometimes find it hard to decide if a need is complex, e.g. lengthy supervision for eating. To me, as an experienced speech and language therapist, it's not exactly complex, it just needs a lot of time. Any thoughts on that?
You see, I guess what I do, Joe, is I go, well, it takes a person without Huntington's disease, I don't know, 20 minutes to eat a sandwich. Or so I take the average, and I go, well, okay, if that person needs social care to do that, to assist them with that, and actually there are risks involved with if we go any faster, i.e. beyond the 20 minutes that's allocated to them, what are the risks of that? So in other words, okay, if we rush the food consumption and the support, is choking going to occur as a result? Then for me, it becomes a complex intervention, because it's not a purely social care need at that point. So in other words, if it can be provided in the time allocated, then that's fabulous, and there are no risks, i.e. to health, involved. But thereafter, because of that person's support needs and because of the risks due to dysphagia, then absolutely that becomes more complex.
So I think all that remains to say is thank you very much for doing this. Yes, we're just getting some messages through saying thank you very, Alex, it's very helpful. So that's great. And thank you for everyone who's taken the time to fill the poll in. We appreciate that. And so thank you again, Alex, for taking the time to prepare that. And I think that's been really useful and helpful, because it's such a complex area, and one I think where every time it comes up, it's worth refreshing about you know, what the process is and about some of the complexities of it.
Definitely. It's a I think in a sort of an arena now that we find ourselves in, where people are fighting literally for care. We, as advocates of people with Huntington's disease and their families, really need to get good at this stuff.
Great. Okay. Well, thank you very much, Alex. Much appreciated.